And the camp that I'm representing in this conversation is the biology or biological psychiatry camp, which might be summarized by saying you need a healthy internal environment, meaning your biochemistry, your nutrition, your microbiome, your hormones, and an external environment that supports health. So again, we're kind of looking today at depression from the perspective of biological psychiatry and only a very small slice of that. So that, of course, leaves out many other conversations we could have on this topic, but I'll let you access my perspective on some of those conversations in the document that you can download from the internet. So I'm going to focus right now in this presentation on depression mimics and contributors, just for the sake of completion, including the fact that any, all, and each of the nutritional deficiencies can cause mood, behavior, and depression disorders. I'll talk about biological plausibility relating vitamin D to brain dysfunction. And then in part number 4, I'll talk about clinical evidence. So again, this entire presentation has 4 components. The introduction and contextualization will be available online. Then I'll talk about parts 2, 3, and 4, depression mimics and contributors. That's part 2. Part number 3 is biological plausibility of vitamin D in mood and behavior disorders. And then part number 4, of course, we'll focus on looking at clinical evidence. And we're going to look through about 25 years of clinical research. So having couched it as such, let's move forward right now and jump into the first part. So this is part number 2. Part number 1 on vitamin D deficiency in adults, focused in on pain. So I invite you to have already reviewed, hopefully, that video, and then retain some of that information so you can build upon that information in today's presentation. I previously reviewed what are the 3 locations of physical examination for vitamin D deficiency in adults. Name at least 3 mechanisms by which vitamin D deficiency most directly contributes to pain. I think those top 3 will be quite obvious to you after watching the part 1 video. And then name at least 3 more supporting mechanisms by which vitamin D deficiency contributes to pain chronification. You should be able to name at least 3 more, if not 6 more. Question number 4 in my quick review quiz. What is the defining and differentiating level of 25-hydroxy vitamin D at which parathyroid hormone levels become normalized? That's a very specific number. Obviously, you could go plus or minus a little bit, but the number for this level of vitamin D that normalizes parathyroid hormone levels is actually quite precise. So give or take a few percentage points, we all should have pretty much the same number there. What is the physiologic impact of altered parathyroid hormone levels, and how does this correlate with population trends in general health? So those are some questions that you might be able to answer to then build on to that foundation as we advance the conversation today, focusing in on depression and mood disorders as related to vitamin D deficiency. For the sake of completeness, I am going to allow myself 2 pages to talk about depression mimics and contributors, and then we'll dive into biological plausibility, and then 25 years of clinical evidence. So I think that depression is probably one of the most overused terms in casual conversations and certainly within medicine. So let's talk about some things that kind of look like depression, but which are not depression per se. So we all use the term depression, but depression might be a lot of different things that maybe aren't the medical view of depression, which of course needs drugs. And certainly some people need drugs if they're in an emergency situation, if they're in a crisis, if they're violent, if they're delirious. Let's sign them up for some chemical sedation for a while until the emotional storm or the inflammatory storm kind of passes and they're able to regroup and then kind of regain maybe some new resources to help them cope with whatever problem they were having in their existence. But let's not call everything depression and then think it needs neurotransmitter balancing and pharmacotherapy. Let's not do that. Let's think about some other words that we could use to describe situations when people might be presenting with what we might otherwise want to call depression, but it might be something else, such as disillusionment, disorientation, despair, nihilism, neuroinflammation, boredom, creative overwhelm, burnout, exhaustion, or so-called moral injury. That's the new phrase, at least in the medical world. Overworked and under-rewarded. Deficiency of any vitamins or minerals will cause depression and eventually behavioral disorders. Jealousy, feeling misunderstood by significant social connections, unable to get effective treatment from doctors, leads to frustration, despair, and angst. Shame, unhealed wounds, traumatic childhood, sleep problems, insufficiency, poor quality, or sleep apnea. Hypothyroidism can certainly present as depression, as can hypogonadism and hypoadrenalism. Poor social skills. Some people simply don't play well with others and they don't learn from their mistakes, so they keep repeating those mistakes, and so their social interactions are unsatisfactory or traumatic, and they have to eventually learn some good social skills. Number 20 here on my short list, which is Discordant Psychoepistemology from Barbara Brandon. Weakness, fatigue, exercise deficiency. So we all know that exercise helps alleviate depression through various different mechanisms. But what we could also state is that, therefore, by definition, lack of exercise would be expected to lead to depression. And so we could describe or diagnose people as having exercise deficiency if they're not moving enough. Obesity and diabetes both contribute biologically to depression, if not sociologically as well. Number 24 here, gastrointestinal dysbiosis, but perhaps other locations of dysbiosis, such as parenchymal dysbiosis within the brain. Number 25 on my list, starting in 2020, we see a lot of people depressed because of house arrest of innocent people, resulting in bankruptcy, social isolation, inability to exercise, paradoxically there, inability to socialize, closure of schools and businesses, all brought about by political mismanagement of healthcare problems. And chronic pain can also lead to chronic depression, not simply because people are in pain, but because of changes in brain metabolism and physiology caused by the chronic sensory stimulation being perceived as pain. So we could look at this entire list and consider these items when we want to label someone with depression, and we can look at a few select items on this list and kind of interconnect them and see how these things relate one to the other. And I'll invite you to take a look and consider all of those options, but we're going to move on and now talk about biological plausibility of vitamin D causing mood disorders, behavior disorders, and anxiety and depression. So let's take a look at depression and behavior and mood disorders as a manifestation of a problem or imbalance within the brain, not necessarily a medical diagnosis. So here we're about to focus in on biological plausibility, and this will help you kind of have some framework and language to explain how vitamin D can actually affect brain function. So again, let's answer that question. How could vitamin D deficiency manifest as brain or mood disorders? Number one, the nuclear vitamin D receptor modulates 3,000 genes, any one of which could affect mood and behavior. The membrane vitamin D receptor also modulates rapid responses at the level of the cell membrane, and that affects certain second messengers, which also have effects on nervous tissue physiology, therefore brain function, therefore mood, and therefore ultimately behavior. The so-called active form of vitamin D, calcitriol, activates